to tonight's webinar on the Affordable Care Act under the Trump administration by Tim Jost. My name is Joe Longacre, and I'm a member of the board of Mennonite Healthcare Fellowship, which is sponsoring tonight's program along with the Pre-Professional Health Society at Eastern Mennonite University and the EMU Students of Nursing. The base location for tonight's program is the Suter Science Center at EMU in Harrisonburg, along with 4 satellite locations, including EMU's campus in Lancaster, Pennsylvania, Bluffton University in Bluffton, Ohio, Goshen College in Goshen, Indiana, and First Mennonite Church in Iowa City, Iowa. And I should mention that here, as well as I believe the other 4 locations, there are 3 handouts at the back if you haven't already picked one up. One is general information about Mennonite Healthcare Fellowship, including our meeting this summer at Bluffton University in June. Secondly, details about Mennonite Healthcare Fellowship's 2018 student essay project, and an outline of the speech by Tim Jost on the Affordable Care Act under the Trump administration. Other members of Mennonite Healthcare Fellowship Board involved in our program tonight are Luba/Chiva, who is president of the board and in Iowa City, Iowa, Matt Thiessen, who was very involved in setting up the webinar tonight, and Kenton Durstein, who will moderate the presentation by Tim Jost, and specifically responses to his presentation by Kathy Rittenhouse, Associate Professor of Nursing at EMU, and Davi Moyer-Diener, an emergency room physician here in town. Kenton is a member of the faculty at Eastern Mennonite Seminary. Timothy Stoltzfus Jost, JD, is Emeritus Professor at Washington and Lee University School of Law in Lexington, Virginia. He is co-author of Health Law, used widely throughout the U.S. in teaching health law, and also the author of Healthcare at Risk, a critique of the consumer-driven movement, and several other books. Jost is a contributing editor at Health Affairs and has been a frequent contributor to Health Affairs blog. He has also written numerous articles and book chapters on healthcare regulation and comparative health law. Please give your attention to Tim Jost as he describes the Affordable Care Act under the Trump administration.
Thank you, Joe. They tell me that this mic is going to make it so that you can hear me. I sometimes drop my voice, so if you cease to hear me, let me know. 8 years ago, next month, President Barack Obama signed into law the Affordable Care Act. The ACA, which came to nearly 1,000 pages in official print, marked the most dramatic change in American health policy in a generation. The Obama administration spent the next 7 years implementing the ACA, generally in the face of considerable resistance from Congress, the states, and the courts, but achieving a substantial improvement in access to health care, particularly for low-income consumers and consumers with health problems. In November of 2016, Donald Trump was elected president, promising to repeal the ACA. The 2016 election also returned Republican majorities to the House and Senate, again committed to ACA repeal. Although Congress began 2017 by adopting budget reconciliation instructions that would have allowed for repeal of much of the ACA with a simple majority of vote, and although the House of Representatives passed legislation partially repealing the ACA in March of 2017, Senate Republicans repeatedly failed to follow suit. Congress finally succeeded at the end of 2017 in adopting tax legislation that repealed an important provision of the ACA, the penalty attached to its individual shared responsibility requirement, but it mostly remains in place. In the absence of congressional action, however, the Trump administration has taken a series of steps to undermine key protections of the ACA. The administration's efforts to do so got underway slowly, but the pace of its actions have been increasing. The effectiveness of some of these actions has been mitigated by the states, the courts, or insurers and consumers. Other steps, however, have in fact had an effect on rolling back ACA priorities and are likely to have a greater effect in the future. I begin this talk by describing the ACA, its goals and accomplishments. I will then describe the actions that Congress and the Trump administration have taken so far to roll back the ACA. Finally, I will discuss briefly the future of the ACA under the Trump administration. Barack Obama was elected president in November of 2008 with a 9.5 billion vote margin. The second half of 2008 had seen the most serious economic crisis the United States had experienced in decades. Unemployment had soared. As individuals lost their jobs, they also lost their health insurance. The number of uninsured had been growing slowly for years as healthcare costs rose and small employers dropped coverage. But in the fall of 2008 and throughout 2009, the numbers of uninsured climbed to over 50 million. Over 16% of the population was uninsured. 2008 also saw the election of a House and Senate dominated by Democrats. Democrats had a 257 to 178 member majority in the House, and by the summer of 2009, Democrats and independents had a filibuster-proof majority of 60 votes in the Senate. President Obama and the Democrats in the House and Senate had been elected on a promise that they would reform healthcare and set out immediately to do so. On November 18, 2008, 2 weeks after Barack Obama was elected president, and 2 months prior to the inauguration, Senator Max Baucus, a moderate Democratic chairman of the powerful Senate Finance Committee, released a white paper that articulated a widely held consensus as to what health reform would have to look like in order to be adopted into law by the 111th Congress. The consensus advanced in that white paper saw a successful proposal to expand insurance coverage would have to be focused on minimally invasive reform, fixing the nation's dysfunctional individual and small group insurance markets and expanding Medicaid for the lowest income Americans. Most Americans were already covered through their jobs or by government programs such as Medicare and Medicaid, and were satisfied with that coverage. Any proposal that would disrupt their existing coverage would be poorly received. The key elements of what would emerge as the ACA were evident in Baucus's white paper. First was health insurance market reforms. For healthcare to be universally available in the individual market, pre-existing conditions and the practice of medical underwriting would have to be banned. Healthcare coverage would have to be available to all individuals in the individual and small group market, and all would have to be charged premiums without regard to their health status. The status quo under which sick individuals lacked access to coverage at affordable price, or perhaps at any price, would have to end. As the ACA was fleshed out, additional provisions were added to limit discrimination by insurers against individuals with health problems, including a reinsurance program to protect insurers exposed to high-cost cases, and a risk adjustment program that moved money from insurers that covered healthier than average populations to those that covered sicker consumers. But if insurers were going to cover individuals with pre-existing health conditions, healthy as well as unhealthy people would have to enroll. The solution was an insurance purchase mandate. During the Clinton health reform period in the early 1990s, the individual mandate had emerged as the core of Republican approaches to expanding health insurance. The Baucus White Paper endorsed a national individual mandate as an essential component of health reform. As adopted, the ACA also included an employer mandate requiring large employers to provide some level of coverage to their employees or to pay a penalty if individual employees obtained government subsidies for coverage. An individual mandate could not work, however, as long as many Americans could not afford insurance or comply with the mandate without assistance. Though the federal government had long subsidized the purchase of health insurance through the tax system for people with employer coverage, to the tune of hundreds of billions of dollars a year. Those subsidies were limited to employment-related coverage. The white paper articulated a widespread consensus, again reflected in earlier Republican proposals, that means-tested tax credits would be necessary to make the individual market work, to expand coverage in the individual market to the uninsured. These tax credits were supplemented by provisions requiring insurers to reduce cost sharing, such as out-of-pocket limits or deductibles for low-income consumers. Together, the market reforms, the individual mandate, and the financial subsidies became what is known as the three-legged stool of health reform. The white paper, the Baucus white paper, also called for a fourth element, the health insurance exchange, an online marketplace where health insurance plans meeting minimum standards could be compared and purchased by individuals and small groups. Exchanges would introduce competition and choice into individual insurance markets, providing consumers better and more transparent coverage at lower costs. The exchanges would provide a marketplace for consumers to shop for health insurance and make tax subsidies available to the purchasers. They had also been part of prior Republican plans. Throughout the spring and summer and fall of 2009, congressional committees moved forward with crafting these four elements into the ACA. The drafting began with some bipartisan support, but as it moved forward, Republicans concluded that their political future lay with opposing rather than supporting reform, which turned out to be a good call. The bill's final form was negotiated within the Democratic Party, dominated by moderate Democratic senators from the Midwest and Mountain states. As the legislation moved forward, its scope also expanded. The legislation would not only reform the individual insurance market and expand access to private insurance for the uninsured, it also embraced other goals. First, it expanded Medicaid. The Medicaid program had been adopted in 1965 in conjunction with the Medicare program as a federal state public assistance program for the aged, blind, and disabled, for families with dependent children. Medicaid gradually expanded to cover pregnant women and all poor children. The ACA expanded Medicaid yet again to cover all adults and children with incomes not exceeding 138% of the federal poverty level. It also expanded funding for the CHIP program and streamlined Medicaid eligibility requirements. Second, the ACA adopted a number of health insurance reforms that applied across the board to all group health plans and health insurers. It required health plans and insurers, for example, to cover preventive services without cost sharing in adult children up to age 26. It barred lifetime and annual limits and limited out-of-pocket costs. Third, it expanded Medicare preventive services coverage and Medicare coverage for prescription drugs. It also included a number of provisions intended to improve the quality of care in the Medicare program. Fourth, the ACA included a number of provisions intended to reduce healthcare costs. It reduced the growth in payment for Medicare providers and managed care plans, and authorized new approaches to provider payment that could increase efficiency and cut costs. It also imposed an excise tax on high-cost employer health plans, the so-called Cadillac plan tax, which has never been implemented and has just been delayed again until 2021. In fact, healthcare costs grew at historically low rates during the years following the ACA's adoption, although they ticked up as coverage expansions went into effect in 2014, but they are still much lower than costs growth was in the early 2000s. Fifth, the ACA made many changes to our healthcare system that have been almost entirely ignored. It created a host of programs to expand the healthcare workforce. It included an entire chapter creating new tools for fighting fraud and abuse and to improve transparency. Another chapter focused on disease prevention. It created a pathway for the Food and Drug Administration to approve generic biologics. Finally, it included a series of new taxes to fund the program, including increases in Medicare taxes paid by the wealthy, which have extended the solvency of the Medicare Part A trust fund and the progressivity of our tax system. Some of the provisions of the ACA, including most of the insurance reforms, took effect within 6 months of enactment. A number of the most important ACA reforms, however, were not implemented until 2014. These included the Medicaid expansions, the guaranteed issue requirement, prohibitions against health status underwriting and pre-existing condition exclusions, the premium tax credits and cost-sharing reductions, the individual and employer mandate, and the health insurance exchanges. Congress had understood that operationalizing these major changes in insurance markets and creating new institutions would take time, and as it turned out, 3.5 years was barely enough. As we awaited implementation of the 2014 reforms, however, a number of things happened. First, the Republicans gained control of the House of Representatives. At that point, amendments to fix problems that had appeared in the ACA became practically impossible, as did further funding for implementation. There has never been money voted for implementation. Second, state houses across the country were Republican. Congress had assumed in adopting the ACA that many of its provisions, such as the exchanges, would be implemented by the states. The ACA faced immediate opposition from some states, but after the 2010 election, state cooperation and implementation declined dramatically. Third, several lawsuits were filed challenging the constitutionality of the ACA. These initially focused on the constitutionality of the individual mandate. The federal government had arguably never before required individuals to purchase a product, and several states and individuals in an organization sued, claiming that it had lacked constitutional authority to do so. In 2012, the Supreme Court upheld the individual mandate, but did it as a tax rather than as a mandate. In doing so, however, it struck down the Medicaid expansion requirement, leaving the states to decide whether or not to expand Medicaid. Only 32 of the states have done so far, leaving 2.4 million Americans without access to health insurance coverage, including over 200,000 in Virginia. That may change this Sunday. I'm waiting to hear. The 2014 implementation of the ACA exchanges was an absolute disaster. The federal exchange and several state exchanges crashed on the day that they were to open, and it took 2 months before the federal exchange was up and running. Nevertheless, premiums came in below levels that had been projected, and 8 million consumers eventually signed up for coverage. In 2015, 11.4 million people signed up, and 12.7 million in 2016. At the same time, the number of people who enrolled in Medicaid grew steadily. By 2016, only about 28 million Americans remained uninsured, about 9%, down from the 50 million in 2010. There was ample evidence, moreover, that people were getting better access to care and improved financial security as they gained coverage. In November of 2016, Donald Trump was elected president of the United States, with Republican majorities in both the House and Senate. By mid-January, even before Trump was inaugurated, the House and Senate adopted a budget resolution that opened the way for repeal of much of the ACA through a simple majority vote. President Trump took office on January 20, 2017, and on Inauguration Day, as virtually his first presidential act, he issued an executive order that directed the agencies responsible for implementing the ACA to reduce its requirements, provide greater flexibility to the states, and open up interstate markets in health insurance and services. Despite great expectations, however, neither Congress nor the president moved swiftly to dismantle the ACA. The administration's first major administrative action, in fact, was a market stabilization rule. In February, the proposed rule, which was finalized in mid-April, made it harder for consumers to sign up for coverage mid-year rather than during the annual open enrollment period, allowed insurers to refuse to re-enroll consumers who owed them money, until their premiums were paid, cut the 2018 open enrollment period from 90 to 45 days, allowed insurers more leeway in designing cost sharing for their plans, and turned over more regulatory responsibilities to the states. It was not, however, a ACA repeal. It was rather based on what the insurers thought would make the ACA function better. Neither House of Congress took further action until early May, when the House passed by a narrow 217 to 213 margin the American Health Care Act. The HCA also did not, in fact, repeal the ACA. Indeed, it left 6 of the original 9 titles of the ACA completely untouched, and much of the ACA's infrastructure in place. It is rather best understood as an entitlement reform and tax cut bill. It phased out enhanced funding for the Medicaid expansion and imposed either a block grant or per capita caps on Medicaid funding, and eliminated the taxes and tax increases in the ACA. Beyond that, it also removed the individual and employer mandate penalties, changed the structure of the ACA's tax credits, and gave the states more flexibility in enforcing ACA requirements, but it did not repeal the ACA. In the meantime, the Trump administration began to take steps to put its own mark on the ACA, if not to roll it back. It invited states to apply for waivers from ACA requirements, and it also took steps to change the Obama administration's policy regarding contraceptives. Employer plans, abortion and contraceptives are just well, abortion, but then we found out contraceptives are just impossible issues for healthcare reform. Employer plans had been required by the Obama administration to cover contraceptives as a women's preventive health service. Religious organizations were granted an accommodation from this requirement, but many organizations did not accept it, and it did not cover for-profit businesses until the Supreme Court decided to extend it in the Hobby Lobby case. Who knew that for-profit businesses could have religious beliefs? But we found out they could. About 100 lawsuits were filed challenging the Obama administration's rules. In early May, the Trump administration issued an executive order saying that it intended to review the Obama administration's contraceptive policy. In October, the Trump administration issued an interim final rule recognizing an open-ended exemption from covering contraceptives for any organization, business, or insurer that objected to them for religious or moral reasons. The Trump policy was promptly enjoined by the courts, which reinstated the Obama administration policy, and that's where we stand at this moment. Throughout the summer, the Senate tried to assemble a majority to repeal the ACA. With a solid 48 Democratic votes in opposition, Republicans could only lose 2 votes. In the end, the Senate was unable to move an ACA repeal bill. I believe this was largely true because the bills were again focused on changing the Medicaid program, which covers 1 out of 5 people in the United States. The CBO estimated that 23 to 24 million people would lose coverage if the Senate bill was adopted into law. And that was too much to stomach for a number of moderate Republican senators. Moreover, Republicans had for years complained about how the ACA had been crammed down their throats by the Democrats, and a few Republicans were troubled that their repeal bills were being rushed through on a strictly partisan basis with little transparency. In October of 2017, however, the Trump administration, which had so far limited itself to marginal changes in the law, began to take dramatic action proposing alternatives. A proposed rule for permitting association health plans was published earlier this year. Basically, it would permit associations like professional associations or chambers of commerce to offer health insurance that does not comply with the individual or small group requirements of the ACA. The plans would still need to meet some requirements and could be regulated by the states, but were unlikely to offer the kinds of consumer protections ACA plans would, and are likely to siphon off healthier enrollees from the small group and individual market. Another proposal which would permit short-term plans that are not subject to any of the ACA requirements, is expected momentarily, I think maybe tomorrow afternoon. Again, it would offer cheap and limited coverage to healthy people. It would not really help out people who were sick who would remain in the ACA market. Yet another action the administration took in October was to cut off reimbursement to insurers for the cost-sharing reductions they are legally required to offer low-income enrollees. The House of Representatives had sued the Obama administration in 2014, claiming these payments were illegal, and that issue was being litigated in the courts when the Trump administration decided in October to cut the payments off. This move could have destabilized the insurance markets since billions of dollars were at stake, but the states simply required insurers to raise their premiums to cover the cost-sharing reductions, and for most people in the exchanges, the premium tax credits went up to cover the increased cost, and they were no worse off. For people who are purchasing coverage without premium tax credits, however, many of them faced dramatic increases in premiums. A final Trump administration October initiative was to propose new rules governing plans for 2019, and that proposal has not been finalized, but it would allow states to allow insurers to offer fewer benefits and to spend less of their premiums on health care. A 45-day open enrollment period opened on November 1st for 2018. To the surprise of everyone, given the steps that the Trump administration had taken to undermine the marketplaces, approximately the same number of people enrolled as had enrolled the year before, and we've now just gotten final numbers from the states, and total 2018 enrollment is at about 11.8 million. Finally, at the close of 2017, Congress finally took action to repeal a major ACA requirement, the individual mandate penalty, as of 2019. The individual mandate had long been the least popular provision of the ACA and was probably subject to widespread evasion, but the CBO estimates that its repeal will result in 4 million people losing coverage for 2019 and 13 million by 2025. CMS, by the way, just said a day or two ago that it will result in 8 million people losing coverage. It will also increase premiums by about 10%. Congress has also repealed one of the ACA's cost control measures and delayed several of its taxes. So where are we now, a year into the Trump administration? The latest data show that the number and percentage of the uninsured are starting to creep up again. According to Gallup data, the number of uninsured increased by 3.2 million in 2017, the largest increase since they began tracking these data in 2008. The percentage of uninsured adults under age 65 increased from 10.9% in 2016 to 12.2% in 2017. The cost of individual coverage is up significantly. The choice of insurers and plans has decreased significantly. These trends were to some extent underway in 2017, but coverage is continuing to deteriorate. Coverage is increasingly unaffordable to those who do not have tax credits. And we in Western Virginia are at the epicenter. In Charlottesville, premiums went up over 200%. On the other hand, coverage is even more affordable for people with tax credits as the tax credits go up as the costs go up. Short-term coverage and association plans will siphon off the healthy, and the end of the individual mandate will cause many simply to drop coverage. Work premium and cost-sharing requirements and simple increased paperwork, which are now being approved through Medicaid waivers, will probably reduce Medicaid enrollment. Hospital uncompensated care and bad debt burdens will rise. By the end of the Trump administration, if nothing further changes, the ACA compliant market will, I believe, be largely for very sick people and people with incomes below 400% of poverty who qualify for government subsidies. Medicaid will still cover many more than before the ACA, but fewer than it does now. In sum, we have reached a stalemate. People with pre-existing conditions still have access to health coverage, and it remains affordable for lower income Americans. But higher income Americans are increasingly being priced out of coverage in the individual market and are returning to forms of coverage that are skimpier and will not be available to people with pre-existing conditions. Most Americans, of course, retain employer coverage, but that's getting skimpier as well. Medicare and Medicaid remain, although the Trump administration is imposing work requirements and possibly time limits on Medicaid, and Medicare will be up next for cuts. But after 7 years, the number of uninsured is growing again, and coverage in the individual market is becoming less affordable and available. We will see if our nation's experiment in extending coverage will survive, but it is being badly battered. Thank you for your attention. Now I get
Okay, now I'd like to invite Dr. Davi Ware-Diener to come up and Kathy Rittenhouse. As Dr. Longacre mentioned, Dr. Diener is an emergency room physician at Sankara RMH, and Kathy Rittenhouse here is an associate professor of nursing here at EMU. Been here for over 10 years and is a certified nurse practitioner and practices both in the health center here as well as in donates her time to the free clinic as well. So at first, and I'll just say again, I'm Kenton Durstein. I'm the faculty at Eastern Mennonite Seminary. And I invite Dr. Diener to begin response to Tim's presentation.
Well, as you had mentioned, as you guys have mentioned, I'm an emergency physician. I am what I would like to consider a provider of emergency care. I am also a provider of convenient care, and thank in part to the Emergency Treatment and Active Labor Act that was started in 1986. I'm also the provider of last resort for many people in the United States. And it looks like that's going to increase and continue for the time being. As emergency physicians, we represent about 2% of the physician labor force in the United States, and we provide about 30% of the acute care visits to the healthcare system, and we account for about 2% of the costs, both to physicians and the facility fees. That's about 150,000 visits. I'm sorry, 150 million visits combined. So, in terms of how the Affordable Care Act has affected me here at RMH, it's been fairly limited because we never had the expansion of the Medicaid portion in Virginia. So it's difficult for me to speak in terms of how this really worked because it was never fully implemented to begin with. So we still have about 20% of our care is uncompensated care.
Yes, and as Kenton said, I'm happy to represent the perspective of a nurse this evening. Nurses are the largest component of the healthcare workforce, and approximately 33 million RNs in the United States are well positioned to assess and identify concerns with the healthcare system. Nurses have a desire to provide insight and knowledge and collaborate with other healthcare experts to work to address concerns and are trusted members of the community. As my colleague who is a physician in the emergency room said, every day nurses also work in crowded emergency departments units, which are often not crowded due to true emergencies, but crowded due to those who can't afford or can't access a primary care provider for problems that could be more efficiently and effectively treated in an office setting. Nurses are witness to hospital readmissions simply because elderly patients have to choose between affording medication and heating their home. Nurses hear stories of lives, families, and communities devastated by addiction. In spite of having the most expensive healthcare system, the U.S. ranks last of developed countries in efficiency, access, equity, and healthy lives. For the first time in 50 years, American life expectancy has fallen for 2 years in a row to 78.6 years, while in 25 other developed countries, life expectancy remains steady at 81.8 years. This is partly due to the opioid crisis, but to attribute it only to this, and this is the mark. Socioeconomics in the U.S. healthcare system are also to blame. Influential factors include the profit motive for prescription drugs, limitations to access to care for the elderly and Medicare, the lack of a strong safety net to mitigate effects of economic hardship. It's the position of the American Nurses Association Code of Ethics, Provision 8, that health is a universal right, that nurses must collaborate for health, human rights, and health diplomacy, and that nurses have an obligation to advance health and human rights and reduce disparities. The position of the American Nurses Association is consistent with the approach of the conceptual framework used in nursing education here at EMU. This framework identifies a safe covenant relationship between the nurse and the patient based on principles that include partnership, empowerment, justice, and advocacy. This conceptual framework is aligned with EMU's Anabaptist identity and mission in Micah 6:8 to do justice, love mercy, and walk humbly with God. This problem, this issue may seem well out of reach and overwhelming to many of us. I know it has to me at times, but I would encourage everyone that there are things that you can do as individuals. First, you can take responsibility and accountability for your own health. That's a big step. Second, we can all contact our elected officials and representatives, both at the federal and state level. As our speaker alluded to this evening, Virginia chose not to enroll Medicaid expansion in 2014. But in this legislative session currently, a bill is up for a vote to expand Medicaid in the state of Virginia. So if you haven't already contacted your elected official to ask them to vote for that, I would encourage you to do so. It would help close the gap of coverage for over 200,000 Virginians that are working and can't afford health insurance and don't qualify for Medicaid. I would also encourage you to vote for another piece of legislation that's currently up for vote in the session this year, to allow nurse practitioners to practice to the full scope of their education and training. This would improve access to care by improving access to primary care providers, especially in poor and underserved areas. So although this seems like a big issue, there are things that we can do about it. And I encourage you to think about those things.
Can I respond?
Yeah, so Tim, welcome you to respond.
First, I'm glad for what you had to say about emergency care. If you look at international surveys, the United States is among the worst in developed countries for access to medical care after hours and on weekends. And I think one of our biggest problems is you've been at work all day, you come home, you find your child is sick, medical offices are closed, they come see you. In fact, studies that have been done have found that although we all hope that with Medicaid expansion, people would use emergency care less, in fact, they use it more because that's what there is. And I think that ties directly with what you're saying. We had nurse practitioners who were available after hours, who could see people with problems that are true emergencies, but are worrisome. I think our system would run a whole lot more smoothly. The difference between having Medicaid expansion, and there are probably 5,000 or 6,000 people in Rockland County and Harrisonburg who would be eligible to expand, is that you would get paid. So you may not necessarily see fewer people right away, although the hope is that as people get used to having coverage, they will use their coverage better, more wisely, but you would at least get paid. With respect to nurses, again, I think it's really important to let nurses practice to the full scope of their practice so that doctors can focus on what they are trained to do. And again, I think that's a place where we kind of lag behind other countries. The Affordable Care Act was not a panacea. I think it helps. I think there's lots of evidence that it helped. And I'm talking too quietly, but we still have lots of people who don't have adequate access to medical care. And one issue that you raised, which I'd like to emphasize, is I've just been reading a number of books about social determinants of health. And there is a very direct correlation between poverty and the cost of living. And we all think, we all know we should be healthy. We shouldn't smoke, we shouldn't drink too much, we should exercise every day, we shouldn't eat too much, we shouldn't eat fatty foods, we shouldn't drink fizzy drinks. But one of the books I was reading said, we all know what the list is, and then went down the list. And then on the next page, he said, another list that probably would be more effective is don't be poor, don't live in inadequate housing, have a good job, take a nice vacation once a year, and there is at least as a direct correlation between that and between the health behaviors that we would all like to encourage. So happy to answer questions.
Yeah, you or Kathy have questions or response.
Good, thank you.
Should we answer questions? People at Bluffton.
We don't have, we hadn't planned to transfer questions from around the, I guess at our other sites. Perhaps
repeat the question, though. If you call
okay.
out a question and you repeat it.
Are there questions from the audience? And we'll try to hear and repeat here.
Hi, I'm a student in Master's of Medicine and recently something that came to my attention very informative was about CHIP funding, and they stated that there was going to be a decrease in the grant throughout the United States. So I was wanting to find a perspective for healthcare, how is this going to affect your field and overall?
Yeah, the CHIP program is the Children's Health Insurance Program, a very important program, bipartisan support, adopted in the 90s, I believe, or maybe early 2000s. And it ran out of funding last fall. And there was a lot of arm wrestling as to what was going to happen with that. But at the end of last year, early in January, we adopted the continuing resolution. They extended funding for another 6 years. The Congressional Budget Office realized that it would actually save money to extend the program rather than dumping all those people into the marketplace. So they extended funding for another 6 years. And then in the budget bill last year, they extended it for 4 years beyond that. so it is now extended for 10 more years. The rate at which the states receive the funding is, I think, scheduled to go down. It had been increased under the ACA. I think it's scheduled to go down a little in a couple of years. But that very important program has been saved. And that's a good example. I mean, there are things that are done in this country in a bipartisan way. The CHIP program has always had bipartisan support, although we ran into some problems with President Bush. And so have programs to try to improve quality of Medicare and control the costs of Medicare. But just in this issue of extending healthcare coverage for low-income people has been very, very difficult as an area to reach consensus.
Another question. Yes.
I'm a retired chaplain from the VA. You talked about, doctor, that you have 20% of your patients are uncompensated for. Seems to me they're all compensated for. Our healthcare costs about $4.some trillion. It's not whether we get paid for it, we pay for it. It's just how is it divided? At what point is that kind of idea going to come? I mean, I hear congressmen say, we can't afford this. Well, we are paying for our health. It's just inefficient and cost shifting.
How would you rephrase the question?
Well, I mean, I agree. We will see patients regardless of their ability to pay. Anybody that comes to the emergency room gets treated the same. But it does stress the hospital system, for example, gets stressed because in Virginia, since we did not expand Medicaid, the compensation was taken away from the facilities. How did that, wasn't there didn't the hospitals receive funding for uncompensated care before, but that was taken away because all of these people were going to start having health insurance and Medicaid, and the Medicaid portion never came through, so that stretches the hospital system. And it does stretch the physicians and providers in the department.
If I could respond to that point, it's actually something I've been thinking a lot about in the last couple of weeks. I could probably talk for about an hour about it because I think it is an important issue. If you look at people who are uninsured, and we tend to think about people who are insured and people who are uninsured, and that's two different universes. In fact, people who are insured have very different coverage. Some people, I mean, I'm on Medicaid or the gap coverage. I walk in, I walk out, I never see the same. That's not true for most Americans. Most Americans end up paying a lot. But for people who are uninsured, when in the first place, there's a lot of just unmet medical need. I have a friend who, I remember a couple of years ago, broke my arm and went to the emergency room and got it set. Everything was fine. And, well, it took a long time to heal, but at least I was fixed. Talked to a friend about it, and he's uninsured, and he had broken his arm too. And he said, I thought about going to the emergency room, and then I realized how big a bill I was going to get. And I decided against it, and he just managed to get through it, treated himself. So there's a lot of unmet medical need from people who are uninsured and who don't go to the emergency room. The EMTALA doesn't make care free. It just means that you get seen, and then you get a bill. And the hospital may decide to waive that bill. The doctor may decide to waive that bill. They may turn it over to collection and collect it. But, so there's unmet need. There's medical debt. A lot of people go into bankruptcy because of their medical debts. Some of them lose their homes because they get home equity loans. Some of them run up huge credit card debt that they're paying huge interest on. So there's medical debt. And then there are programs like you were talking about, the disproportionate share hospital, Medicare, and Medicaid program for paying for uncompensated care. And they cover a lot of the costs, and so does state government, and so does local government. But it's a terribly inefficient system. And you end up with all these secret cross subsidies. And frankly, you end up with hospitals going out of business. We had a hospital in southwestern Ohio that just threw in the towel because they couldn't make it. So it's, you know, they end up coming to see you and you take care of them. But not all of them do. And if they need chemotherapy, that's not something you're probably going to do in the emergency room.
The continuity of care is definitely something that falls through. You know, we take care of the immediate need, but the follow-up care is what chronic illness follow-up.
And you do some of that at the free clinic.
Oh, that it's, the pieces are better connected there if somebody comes on a regular basis, and it can decrease emergency room visits, but you know, people end up in the emergency room that could be better treated in another setting, much more cost-effectively treated.
But frankly, I think that we need to stop thinking about expanding insurance coverage, although that would be nice, and rather think about making services available to people. The comprehensive community health center, we ought to have those. David, you started some in West Virginia. We ought to have those everywhere. And they ought to be available. Anybody ought to be able to use them. They ought to be able to pay on a sliding scale basis for people who need specialist care. Hospitals ought to be compensated for providing that. And I think that if we really did that in an efficient way, that would make more sense than trying to get everybody an insurance card and then the insurance companies collect 20% on top of that. I'm not for a single payer system. I don't. That could be another discussion.
But we'll have another one.
Okay.
But this time we'll transition.
Can we have a question from Iowa?
Oh, okay. So we want to extend that.
Because we figured it was time. So somebody in Iowa wanted to know the projection on the 2018 elections, particularly if a Democrat majority is reached in either House or the Senate.
Well, then we'll have more gridlock. I mean, I think that the Democrats do have a shot at the House. I think that it's less likely they would take the Senate. But I think if they did, it would be even more necessary for the Trump administration to negotiate with the Democrats to try to find some way forward. But President Obama managed to kind of push things through for 6 or 7 years against 6 years against a hostile Congress. And Trump's doing a lot of stuff through executive action right now and continue to do it. I think the Democratic takes over part of Congress. Might be more important as to what happens in the states, because we're seeing very strong resistance from the states against actions that the Trump administration is trying to do. They keep suing.
Guess we'll go to 8 o'clock. So other question.
Can you say a little bit more about rural hospitals? I understand that hospitals in general, like rural hospitals in Virginia, like expanding Medicaid expansion. Some of them will go out of business, and that's even further strain on the system.
Repeat the question.
Yeah, the question was, what about rural hospitals and the problems they face? Rural hospitals are under stress because rural areas in Virginia tend to have a lot of people who would be eligible for Medicaid and covered, particularly in southwestern Virginia. And I believe one hospital is closed. Virginia Hospital Association has been very vocal about the need for Medicaid expansion. I think it is important. This is a whole nother topic. I won't spend much time talking about it. One could argue that our hospital system in the United States isn't very efficient. We had a hospital expansion program that was started in the 1940s, and we built a lot of very small hospitals. And with modern transportation, it may not make sense for every small community but they still are very much the center of the communities. They're places where people receive emergency care. And I think a very important argument for Medicaid expansion is saving lives.
Another question?
Can a question be asked from Bogota, Colombia?
Sure.
Colombia has a great health care system.
This is from a student who's in Bogota, Colombia. He asks, I'd like to hear, are there any ideas or proposals for increasing primary care?
Yes, I mean, the Affordable Care Act actually contained an entire title on workforce reform that contained a number of provisions for funding primary care. It included a provision to increase Medicaid payments for primary care, which unfortunately lasted 2 years. It did contain a number of provisions to focus on that. Those kind of got lost in the weeds. I said they kind of got lost. I think a lot of those programs were never fully funded. But maybe you could talk a bit more about that insofar as nurses are concerned.
Well, I think that that's definitely in the state of Virginia, at least, and many other states. Virginia is only one of 12 states in the country that have not allowed more independent practice for nurse practitioners. So I have gone to school with people and know people that graduate as a nurse practitioner and go across the state lines to work in Washington, D.C. because they can practice there. So we're losing qualified primary care providers because of the restrictive laws in Virginia. So I think that's certainly an area that has potential, at least in Virginia and several other states.
Now that the Trump administration has cut CSR payments in the individual market, do you think he's going to go after the premium tax credit next, considering that the market has remained relatively stable? Oh, I'm getting used to figuring out.
Yeah, as I said, Trump cut the cost sharing reduction payments for the health plans. And the question is he also going to go after the premium tax credits? The legal status of the cost sharing reduction payments was very questionable. It was questionable because the House of Representatives filed a lawsuit saying that they had never been appropriated. You can't spend money in the United States without appropriation. The lower court sided with the House on that, enjoying the payment. That was on appeal. I think there was a case there but they were legally questionable. So the Trump administration decided that they were not going to make them anymore. They were not legally obligated to. There's no question about the legality of the premium tax credits. And so I can't imagine the Trump administration Every day I think I can't imagine, and then it happens. But I think it's very unlikely that the Trump administration will go after the premium tax credits. But what's happened is that the premium tax credit, the cost is just going through the ceiling. I mean, it's costing billions of dollars. And having eliminated the cost sharing reduction payments, since they're all being made up through premium tax credits and then some on top of that, has proved to be a very, very expensive decision for the federal government. I mean, it may be something Congress looks at. They were going to change the way in which they were paid under the various bills that were considered by the House and Senate. But I don't think it's anything that the administration can get on its own.
You might have, here's a question.
You have good insurance. Why can't we all have that from your age all the way down to your babies? What's the problem? It's too expensive, or why can't Medicare be for all?
Good question.
Repeat it.
Why can't Medicare be for all? I mean, the problem is that 80% of 90% of Americans are covered. Most of them through employer-sponsored coverage. Many of them through Medicare. and moving from that system to a system of Medicare for all. In the first place, I don't know that I would want Medicare for all, because Medicare has some important limitations. It doesn't have catastrophic coverage. It's kind of weird in the way the cost sharing. But anyway, having government funding for everybody, politically that just cannot happen, I don't think, because you're going to go to people and say, we're going to take away the coverage you have now that you're perfectly happy with, and we're going to give you something else. And that something else is going to be managed by the federal government. I mean, that's going to be demagogue to death. You'd be seeing nothing but nonstop. In fact, every state that has tried this has lost decisively, because there are just millions of dollars of ads flooding the airwaves telling people about the government is going to take away your health insurance. The other thing is that, and this gets back kind of to your question, it would make costs totally transparent. Right now, I mean, I'm on Medicare, but for somebody who's working, how many know what their health insurance costs? They know maybe what their share of the premium is. They may even know how much their employer contributes. They almost certainly don't know how much the tax exclusion subsidizes their coverage. And all of a sudden, that would all stop, and you would just have a big tax bill. And it would increase your taxes by maybe 10%. I mean, to 10% of your income, or 8% or 10%. And people would say, oh my God, I don't want to pay that much for healthcare. I mean, we're kind of protected in this country by the fact that nobody knows what's going on. If people knew what was going on and how much they were spending on healthcare, it would really bother people. So I think that politically, I don't see how we can get from here to there. But I'm just so happy to be on socialized medicine. I just walk into the doctor's office, I walk out again, never being sick.
Can I ask a follow-up question? Why can't I buy Medicaid?
Well, I mean, that's another way of doing it, allowing people to buy into Medicaid. And Nevada passed a bill that would have allowed that. It was vetoed. New Mexico's thinking about it. We can't even get Medicaid for poor people in Virginia. But that would be another way to do it. The problem, I mean, one problem there is that even though Medicaid would pay you for services you're now giving for free, hospitals claim, and maybe it's true, that it doesn't cover their costs. And so you would have that many more people who were being subsidized by somebody else. Should we take one more question?
Let's take one more.
You were at a question?
Well, it was more of a comment, actually. Your explanation about the Medicare for all, the one flaw I see in that is that that's assuming that the cost of healthcare is exactly what the cost of healthcare is.
Yeah.
And that is a fallacy. That is why we have examples all around the world of how to do healthcare better, with better outcomes, with at most half the cost we have, because it doesn't cost that much. So one of the questions I would have, and maybe it's a question comment, is I don't think the answer comes from the legislative environment, because they will always politicize, they will always negate getting at the core of reducing healthcare costs, getting at the core of improving outcomes. The only way to change the system has to be from grassroots efforts. It has to be for innovative ways to change the way healthcare is done, to prove that it can be done cheaper, better outcomes, more coverage for all, so that that gets attention. Because I think the more we talk about the political climate and the posturing and the complaints of cost of healthcare, which is erroneous, it's false. It's an inflated number that shouldn't exist, but it does. And it's not because of the care providers.
Well,
because of other aspects to the system.
Let me respond to that, because I don't entirely agree with you. I mean, God bless you and good luck in changing it from the grassroots. And I'm sure there are many things that could be done. However, every dollar of healthcare costs is somebody's income or somebody's profit. And I have never met a doctor who said, I'd really like to work for less money, or a nurse, or a hospital administrator, or an insurer. And they all are much more effective at lobbying than we are. So unless you can find a way to change the system, and maybe there is a way, that does not involve politics, that does not involve changing the way things are paid for. I don't see it. I don't see how it can happen. I mean, we had a. We're running over.
Yes.
Okay.
Well.
I'll talk to you afterwards. We had an experience with the German healthcare system that was just wonderful. My wife had a very serious accident, hospitalization, series of surgeries. It cost us a tiny fraction of what it would cost here. The doctor said to us, I earn a third of what my friends in the United States earn, which is enough for me. It isn't enough for them.
But he didn't have $200,000 school debt.
The taxpayers and insurance companies pay for 90% to 95% of medical education. I would be glad to pay for the remaining 5 to 10% just to get that issue off the table. No, those are AMA figures.
Well, many good questions. And the conversation continues, the surface of many issues and questions, and so it was a rich time. Let's give our panel a hand.